So we have learned about bone, we have learned about the type of fixtures, we have learned about the basics of protocol of placing the fixture into your bone at the desired depth and angulation. All this by planning. And when we are looking at planning, we are also looking at the prosthetic component before we place the surgical component. Fixture is the surgical component, and your crown or the teeth that you would desire to give is the prosthetic component of the implant. And if everything has gone well, then the most important step that is required to ensure that your phase one is successful and phase two survives well and is successful is by your impression techniques. And there are a varied ways and very number of components that are involved to ensure that you have recorded the angulation of the implant into the in the jawbone and transferred the information to your lab to fabricate the right kind of processes that you want. So impression techniques in implant dentistry is what we will start. As mentioned, the success of implant depends on its osseointegration and the passive fit of the processes. As implants are functionally ankylosed with direct contact with the bone, they lack the inherent mobility of the periodontal ligament. Hence, they cannot accommodate distortion or misfit at the implant abutment interface. What does this mean? That you don't want your implant seated in one particular position, which is a rigid component, and you put try to fix another rigid component through the help of the abutment screw, but which is not seated perfectly or angled in a ideal way to dissipate the occlusal load, then we are going to have issue with the survival of the implant or the success of your processes. Long-term clinical success of implant-supported prosthesis is dependent on the passive fit of the abutment. This passive word I would like to stress is only because that shows that there is no strain on the abutment screw either directly due to the misfitting of the abutment itself into the conical connection or a load due to a lateral strain or occlusal load because of the design of the processes. This is very important to ensure that the abutment is fitting passively into your implant. This will cause, if it is not fitting well, then what we will come across is screw loosening, an unfortunate event, screw fracture. More times out of 10 will make your implant useless because it's not always easy to retrieve a fractured screw unless that fractured component is not it's not tight into the fixture, then it is easier to remove, but otherwise it's a nightmare. And as a initial days, you don't want any of these things to happen. You place an implant due to your enthusiasm and planning today. And suppose this is, we are talking in the month of September, and in January or February after routing, you realize the patient is back either with screw loosening or a screw fracture. You don't want to be in that. Believe me, if the abutment is not fitting well, you will have plaque accumulation resulting in peri-implantitis or loss of bone around the neck of the implant abutment union. And a lot of times, if the patient feels that, oh, I have a implant, it's moving, it's fine, but I can eat, they continue using the implant with the loose prosthesis. And what happens is the implant collar, if it's a thin implant, then it can give way and you have an implant fracture, which again means either you leave the implant the way it is, or you have an explantation procedure where a lot of bone around the integrated implant has to be removed for the fixture to be retrieved and a new fixture, if bone available, can be placed. So implant impression is one of the most important steps in achieving passive fit by accurately relating an analog of the implant or implant abutment to the other structures in the dental arch. What does this mean? These are the components, as I had said. We have the implant fixture, we have the abutment, and we have the abutment screw. And the final thing that goes over the abutment is the implant crown or the prosthesis, as we had provision to begin with. A few components, as I had said, impression coping, one of the key things that we need to have in the prosthetic kit of any of your implant system. A good implant system will ensure that they have all the right prosthetic components or impression components which allow you to give the ideal processes. So impression coping is nothing but they facilitate the transfer of intraoral location of the implant or abutment to a similar position on the lab cast. Impression copings are two types. They can either be screwed into the implant or they have a snap fit kind of ones also. Then we have the closed tray or the open tray. Then we have the implant analog or the lab analog, which is nothing but almost a duplicate fixture made out of an alloy and not titanium, which can be used for transferring the position of the implant intraorally into the lab cast. This engages into your impression coping after the impression has been removed, and you screw this into the impression coping and send it to the lab for pouring of the models. So implant impressions are classified as conventional and digital. Since we are into basic implantology, we will discuss a lot about the conventional, but we'll also give you a bird's eye view of the digital because that is the way ahead. And we hope all dentists have access to this beautiful science. For conventional, we have two options. One is at the time of the surgical placement, if you are planning to do an early load, or since implants are fixed in a particular angle and you have the primary stability in place, you can take an impression at the surgical phase or delayed after 2 to 3 months after the healing. At the time of surgical placement, you have choice of bone indexing with tray or with jig. And as far as the implant placement, delayed placement is concerned, delayed loading, you have an implant level impression or the abutment level impression. In both types, you have a closed tray, open tray, indirect or direct. We will show you and one by one to understand each criteria and category, and you can decide as per your case what suits best for your practice and also for the lab support that you have, because few have multiple steps back and forth, which requires your patient to visit your office multiple times, and few ensure that you can have the impression done, ensure that you have the indexing and the jig, and you can directly call the patient for the prosthesis placement. So surgical indexing is the process of recording the uh, position of the implant 040 relative to the adjacent teeth and opposing occlusion at the time of implant surgery. The purpose is to communicate the position of the implant to the lab technician, who can then generate articulated models and ensure that you have a proper aesthetic emergence profile and an ideal abutment choice so that you can make the ideal restoration with the right kind of occlusion. So this is how bone indexing with tray is done. You have reflected your flaps. You can see the implant fixture. You put your impression coping at that particular time. Here you can see an open tray impression coping, which is much longer than the closed tray. And you can see on the right side that you have a custom tray through which there is a small perforation allowing the open tray coping to come out and access the hex. This is how the impression looks. Master cast has been made at the bone level, so you know what kind of where your abutment margin should be, your abutment and crown in place and in situ, and you have a wonderful emergence profile. Uh, you can sometimes give a secondary incision if the time for the lab to deliver your crown is too long. You can just give a small infiltration during the phase of fixing the crown, give a small reflection of the flap, just a little bit, tiny bit, to allow complete seating of your processes, tighten your abutment, torque it to the desired manufactured prescribed torque levels, and take an X-ray that everything is fitting fine. One small suture, and you have a perfect emergence profile and prosthetic harmony, which will ensure that patient can manage and maintain the hygiene as he would do for normal teeth. Bone indexing with jig. Indexing implant position technique by using open tray impression copings splinted to a surgical template is a simplified procedure. So as I said, there are many ways to take a record and impression. Some require lab support back and forth. Some ensure that you eliminate few steps and make sure that your recording is 100% so that the patient only has to come back for fixing of the final crown. So you have made this kind of surgical jig, and you place your abutment with the pattern resin over there. You make sure your jig is stabilized. You put your soft body around the space created between the jig and your impression coping, and you record your position of the implant. Then you have a master cast where you have ditched out the entire space, and you place this surgical guide kind of template onto your adjacent teeth and ensure that your spatial recording of your implant position is perfect and a crown is fabricated and you can see it in seat. So conventional delayed loading impression protocol involves closed tray and open tray. What are closed tray impressions? They are tapered copings, single to the implant placement. Ideally, can be used if you have limited interarch space where you cannot use the open tray because they are much longer than closed tray. Then, if patient has a tendency to gag, then you cannot have an open tray because the tray size is required for open tray impression coping are larger. And if you have a difficult to access implants in posterior region, you have placed an implant in second molar where there is a opposing second molar of the mandible and you don't have enough space to use your prosthetic screwdriver as well as put a open tray coping, you can use the closed tray component. Advantage is less technique sensitive than open tray. Disadvantage cannot be used in multiple implants. Why we say that? Because if you have, however well you have executed your surgical protocol, as we always say, bone guides the tone. So we do a lot of course correction during the implant placement. If you have multiple implant positions like a canine and a molar or an anterior, anatomically you will have different angulations. And if you are trying to retrieve that tray back as an impression, you will not be able to pull out the tray without damaging or distorting your impression. That is why it cannot be used for multiple implants or non-parallel implants. Not always. So closed tray is used to transfer copings connected to implants. Radiograph is taken to ensure that your coping is fitting well onto your implant fixture. You make the impression, remove the impression coping from the fixture, attach the lab analogs or implant analogs and to the coping, place it back into your impression and ask the lab to pour your cast. Closed tray impression is something what you can see on this model. This what you can see on the left is fixing the closed tray impression. What you have on the right is the coping cap, which gets oriented into the impression, where gets picked up into the impression. You put light body around the area of interest, use the heavy body to ensure you have a nice rigid impression. The details as well as the accuracy is very important. This is how the impression looks. This is how you place it back into that yellow comfort coping cap. It can go only in a particular direction because of the geometrical design. It will either have a hex or a flat surface which gets oriented. Now this easily allows you to transfer the information of the lab implant position to the lab technician. Against this, we have the open tray impression. They are square copings, very advantageous when you have multiple implants and non-parallel implants. They are longer, but they also help in accurate replication of the implant angulation. They disadvantages, they are technique sensitive. Why we say that is because there is a way to go about it. You need to splint them if you have multiple implants, because you don't want, when you are unscrewing the lab impression coping, you should not disturb the impression coping, or it should not get rotated while you are doing the unscrewing part, because then that is what will get transferred to the lab as the final position. So splinting is very important. So technique sensitive, cannot be used naturally in patient having limited mouth opening, or you are far back into the oral cavity. So similar thing, transfer copings are guide pin assembly attached to the implant, syringe material injected around the transfer copings, tray filled with either polyether or any other impression material of your choice, excess material removed from the top of the perforation that you have created in the custom tray, so that the hex is easily accessible. Once the impression material is set, you use your screwdriver gently with the two hand support onto the impression tray, unscrew the impression coping, pull out in a particular direction one snap, and attach the lab analog and ask the lab to pour the cast. So this is how you can see they are much longer than your conventional closed tray. You have to make a tray, either cut your existing plastic trays, or you can even ask the lab to make custom trays by taking an impression earlier, or use your previously used diagnostic model that this is the area of implant placement, and the lab will do the needful by making a special tray having enough space for your impression material. If it is too less, then your impression material will not have the right physical properties to have the rigidity as well as the accuracy to transfer your information to the lab. This is how the lab analog or the implant analog fits onto the open tray copings, and you can transfer the information. So the indirect impression technique is a method of making an impression by first connecting the abutment to the implant fixture and subsequently connecting the impression copings to them. The connected abutment is not removed in the abutment level impression. Hence, until the prosthesis is ready to be delivered, the impression cap should be placed over the assembly to protect the connected abutment. Now, this is where you have a straightforward case. You know that the tissue type is thin, and you can directly engage an abutment into your implant fixture, adjust the height of the stock abutment that is available by the company, and you block the access hole. Take the regular impression that you would do for normal crown and bridge, and once that is done, you put a comfort cap onto your abutment so that the patient does not end up damaging his tongue or lip or cheek during the time the process is being fabricated. Indications, multiple abutments, advantages, one-time placement. So as I said, that if you want your patient to visit less, then sometimes you can use this as an option. Very rarely we do this unless and until we are really short on time, or it's a very simple classical case where aesthetics are not important and hygiene is easy to maintain. Then we can use this abutment level impression. So again, summarizing, place the abutment, torque it to the desired torque levels, snap the impression onto the abutment, use the tray material and impression to pick up, transfer the lab analog onto the abutment, and send it to the impression to the lab for impression pouring. So this is what I had just spoken about, that abutment level direct impression is screwing of the final abutment into the implant oral cavity and transferring the impression. And it is similar to taking your regular crown and bridge impressions that you would do for a bridge. Indications again, multiple abutments, advantages, less time consuming, margins can be prepared according to the operator's specification, single appointment procedure. Disadvantages, trimming the abutment in the patient mouth may cause discomfort to him or her. Yes, you are trimming the metal or into your patient's mouth while it is stopped to the desired level. When your diamond burr or a metal cutting burr is rotating around the abutment, which is fixed, there's a lot of times that it bounces off because of the vibrations, and you can injure or cause discomfort to your patient. So you have to be very careful. Try and use an abutment of choice where the modifications are minimum, and that is why I said this is one of the least preferred as far as my practice is concerned. We like to use the regular transfer coping method, or actually in today's this thing we are using mostly digital.
Multi-unit
Using one
abutment
video
open
of
tray
BioHorizon over
technique
here, just
using the
note
direct pickup coping.
the multi-unit options. When you have multiple
Remove the
implants
provisional restoration
and
and
you are doing a
confirm
full
that the
mouth,
abutment
just
platforms
to
are
give you an
free of any
overview.
debris or soft tissue. Tighten the multi-unit abutments or abutment screws to 30 Newton centimeters using a calibrated torque wrench and the appropriate driver.
Quick feedback.
Place the multi-unit direct pickup copings onto the multi-units using the long coping screws and hand tighten. Try in the custom impression tray or modified stock tray to verify that the coping screws protrude through without interference. Syringe medium or heavy body material around the coping bodies, leaving the screws exposed. Load the impression tray with material and make the impression. For easier removal of coping screws, remove excess material before it sets. Once the impression material has set, remove the coping screws by hand and remove the impression tray. Verify that the impression material is completely adapted around the multi-unit direct pickup copings. Replace the provisional restoration and torque the prosthetic screws to 15 Newton centimeters. Attach the multi-unit abutment replicas to the direct pickup copings in the impression and insert the long coping screws through the access holes in the impression tray. Hand tighten the coping screws. Send the impression to the lab. Verify that the copings and replicas are properly assembled. Syringe soft tissue material around the replicas. Fabricate a working model using minimal expansion, high hardness die stone. Articulate the model according to normal laboratory procedures.
So this is how you record for multi-level abutments. That was just an overview for doctors who are already doing dentistry, implant dentistry, and are placing more than 2 or 3 implants or doing a full mouth. It's just a brush up, I'm sure. But for doctors who are looking to start implantology, multi-level abutments will be something that we'll discuss at a deeper level and at a separate interaction and a course. Coming to the advantages of implant level and abutment level, the coping requires subgingival placement of copings, whereas in abutment level, the supragingival margins hence easier. As I said, if you have a thin tissue type at abutment level, then you can think of using the abutment level impression. Otherwise, the choice should always be implant level impression, which is to be done by using the transfer impression copings. Abutment selection and preparation. At implant level, it is done in the lab. The lab will decide the right kind of abutment, or if you are wanting to stay involved in the entire case, then you can also design and decide what kind of abutment you would want the lab to make. If you are doing at an abutment level, then you only have to decide what is best fitting into the scenario and send the information to the lab. Abutment modification, if you are doing an implant level, not needed because you select a particular kind of abutment or you make a smart custom abutment or a castable. Whereas if you take abutment level impression, then you need to modify it in the mouth. And as I said, it can sometimes create discomfort. Custom abutments are always available at abutment level impression, but when implant level impression, but when you're doing abutment level impression, then they are not available. We have a few raised hands. Pardy, what do you want me to do with that? Should we take them at a later stage with a question answer session?
Mhm.
You can request the participants who are raising hands to type their questions, and then we can answer them during the question answer session. Or if you want me to stop and answer few right away, we can do that.
Okay, we saw Hollins have a question, maybe hands up.
We have Dr. Bonetto who wants to speak. Should I allow him to talk?
Or maybe some mistake.
Okay, looks like he's put his hand down. So we'll wait for him to re-raise his hand. So again, some advantages and disadvantages for closed tray versus open. With regard to impression technique, the closed tray method showed lesser dimensional changes than the open tray. And some studies show that there is no significant difference between the dimensional changes between the two impression techniques. Well, we can say that, but if you want to believe by experience, then the open tray definitely has more accuracy and more reliability, especially if you want to reduce your patient's office visits. Then we would recommend that you take an open tray, and that all too with a jig, which I will explain in the upcoming slides. A study done by Dawoodi et al. Comparing the closed tray technique at the implant level with the open tray technique at the abutment level for a single tooth implant restoration revealed that the open tray technique was far superior and more predictable. Discrepancies in axial rotation and inclination of the analogs were noted in the closed tray technique. So what it's further confirming what I just mentioned. Carr compared the open and closed tray techniques with a 5 implant mandibular cast where the intra-abutment divergent angles were less than 15 degrees and concluded that the open tray technique was far more superior. So again, we confirm that we would want to go for open tray, but that does not mean for a single implant or a 2 implant case, you cannot take the closed tray technique. These are similar inferences. Dawoodi et al. And Lu et al. Separately evaluated the ability of different operators to reposition the impression coping analog units into the impression and later described the technique as unpredictable. Repositioning the implant impression coping back into the impression along with the analog attached may result in adjusting or remaking the restoration as copings could not be consistently and accurately repositioned on the impression. So as I was saying that if your impression material is not of adequate thickness or while you are trying to put the lab analog into the impression coping and you use the screwdriver a little more, then you might just about rotate the coping ever so slightly, which will which is what the lab will have the information as. And when you have the processes back, it is either sitting in a different axial position. Why? Because all our implants have internal connection, which have mostly, especially BV or the Korean system, have an internal hex. Hex means you have your abutment which can sit in only 6 possible positions. And if you have recorded your position in a particular angle or information, then the moment the lab has a different thing, what comes back to you will not see it the way you are expecting it to be, and you will have to redo the entire procedure or the impression making. So factors affecting impression accuracy. Factors affecting accuracy of implant impression. One, the technique, direct versus indirect. We have now known that indirect is better. Impression material, always, of course, because that is the primary thing which is helping the recording and transfer of information without distortion. Splinted versus non-splinted, we'll come to that. Splinted always preferred. Splint material, we have a few, but the best would be to go with the pattern resin. The coping design, again, if the company has a good design on the coping, as I said, the geometry, the positioning of the coping back into the impression becomes easier as it can fit only in one particular format. Angulation of your implant again is very important. If it's highly angulated more than 15 degree, then you need to have probably a custom tray or an open tray impression. And lastly, the digital impressions, which we will definitely be giving you a small information about. So direct versus indirect closed tray, you require no tray preparation for closed tray, whereas with open tray, you either need to modify your existing stock tray by yourself or ask the lab to make one. Type of coping used, closed tray, you have the round conical coping, whereas in the open tray, you have a square preferred or whatever your company is giving as an option. Interarch space, again in closed tray with limited mouth opening can be used, whereas the open tray cannot be used where patients have limited mouth opening because the coping screw is much longer. Precision of impression, chances of distortion because of the reinsertion of coping back in the impression before fabrication of master cast. Whereas in open tray, since the entire coping is seating within the impression and you are allowing it to set and then attaching your lab analog and transferring it to the lab, the chances of distortion is less. Splinting of multiple copings in closed tray is not possible, whereas in open tray is possible and is also the preferred choice. So the accuracy of the definitive cast for either technique depends on the displacement level between its implant analog and the impression coping. What does this mean? 14 studies advocate the direct technique. Out of these, 6 studies which compared the report similar results, both technique. Other sources of inaccuracies were identified other than impression techniques such as angulation or coping. So basically, if your implant position and angulation is not too skewed, then you can use the closed technique. In situations where 4 or more implants are used, a greater number of studies showed accurate impression with open technique. For 3 or fewer, half of the studies consider open technique as one of the best offering, or you can also use the closed. In addition, one study reported a similar accuracy between snap fit and metal copings. Now, what is important is the impression material. We have many, but we will just go with the basic right now. Ideal requirement is what we should emphasize on, depending on what your market and your demographics allow. The choice of material should remain the same. Company and product can be of varied choice. It should reproduce the details accurately, should be resilient enough to spring out of the undercuts, because when you snap the entire impression, you have an implant angulation. Sometimes the teeth are in particular angle, but the implant abutment is coming at a different angle. Then when the entire tray is pulled out, your material should have that scope that it will retract from that position and go back to where it was. Wettability, again, very important. Prevent dislodging of components, so it should be rigid enough, and avoiding fracture of the stone when prepared abutments are small. Now, this is very important also, because if the material is too rigid, when the plaster cast is trying to be pulled out, a lot of times the adjacent teeth will chip or break, and then you will have a master cast which does not have the full details. The most commonly used impression material would be polyether rubber base or as the base and polyvinyl siloxane as the soft body. In general, the impression material that uses a putty-like heavy body component which gives rigidity and less viscous wash impression, which ensures the detailing of the soft tissue around the abutment. There are numerous studies done to investigate the accuracy of impression materials. And it was found that polyether and vinyl polysiloxane BPS is what we call impression provide superior reproduction compared to other impression materials. Aguilar and colleagues reported similar distortion effects between PE and VPS. VPS, that is vinyl polysiloxane, demonstrate a statistically significant superior accuracy for distortion of 0.64. Sorrentino and colleagues reported a higher accuracy for addition silicon in the presence of non-parallel implants, whereas polyether achieved the best results with parallel implants. So again, few inferences about the choice of material, but as I said, we should go with the vinyl polyether siloxane, BPS or PE, which are the ideal choice for implant dentistry. Coming to the last part is the splinted versus non-splinted. Now, why this is important is if you are doing multiple implants, you have an edentulous arch or a partially edentulous arch, and you are going to do an open tray, then it is better that we have a splinted impression coping to ensure that you have transferred all the information accurately. So this is how you can see the impression open tray copings which are engaged into your implant fixture. You can use the pattern resin. They are generally red in color, or even this composite, which helps in adapting around the soft tissue to record the soft tissue profile for your prosthesis design. So you can use this as well. You can use a floss thread, which is tied around the upper impression copings in this particular manner. It just acts like a framework. This is the pattern resin that I was saying, the red color pattern resin. It's nothing but actually a cold cure acrylic. And you, once this is done, you snap your impression, pull it out, remove the impression, put your, this is how it will look, attach your lab analogs to the copings and send it to the lab for making the master cast. So despite having no general consistent accuracy conclusion in literature, recent studies report increased accuracy for implant impressions with splinted technique. Nevertheless, few authors have identified potential problems with splinted techniques such as fracture of the connection between the splint material and the shrinkage of the splint material. So these are few factors, yes, which we need to take into consideration, because it's always like that. More are the elements that are involved, naturally we have to try and minimize their negative effects in any procedure. It could be surgical, it could be prosthetic, it could be your daily life as well. So we need to understand the advantage and disadvantage of every procedure, also understand the physical properties of the material that we are using. So if you made everything right, but while pulling out the impression, if your splint material snaps, then your impression has gone for a waste and you have to restart. You have to ensure that you have taken the due care to allow proper bonding of your splint material. So this is how a master cast with multiple implants look. We a lot of times ask the lab to make this kind of impression copings so we send it, and this is how they send us the impression copings with a custom tray. You place it in your patient's mouth. Once they have been torqued, hand tied, you put your pattern resin around it between the joints of your uh, jigs, your lab prepared jigs, and then you take your impression and do similarly transfer with the lab analogs back to the lab. This definitely gives a far more accurate impression, and you are almost sure of your recording. And you can, because these are large processes, you cannot afford to repeat them, nor does the lab do them for free. So it is our prerogative to ensure that we have done all the steps right for recording your information. Coming to digital impression. So this is the new era of dentistry, and I hope most of you all have access to this modern day science. It's a marvel. For CAD/CAM assisted fabrication, digitization of the clinical situation is a prerequisite. For this, two techniques of data capturing are available. One is the intraoral scanning and digitizing the cast made from conventional impression. and later usually carried by scanning in the cast, scanning of the cast. Second is the direct scanning, which is the chair side. So a lot of times what recording we do as an impression, the lab still scan that model and take it into CAD CAM as a digitization, semi-digitization, whereas uh, the digital impressions that we do today with the intraoral scanners are the direct impression into the oral cavity, and they directly transfer a digital file to the lab, and a 3D cast is printed, and you have your recording of the impression. So this is one of the case we have just done before, maybe last week, on multiple implants. You can see the scan bodies in place. The scan has been done. You can see how well the soft tissue is recorded. Also the cast, you can see that all the implants have been well recorded. You have your spatial orientation of your implant positioning. You will have the digital lab analogs to transfer into your 3D cast, and then you can start with a jig trial, or you can start with a metal framework trial for a checking for the passive fit and the final processes. So manufacturers have to offer scan bodies, and fortunately BV concept BV system has the digital scan bodies available for all their implants, and that's the fantastic thing, because that means they are in tune with what is happening and are updated with the current trend in dentistry. This also allows you to explore other CAD/CAM options like the tie base, the custom smart abutments, and that is why the digital dentistry is almost something that will now uh, make the regular impression making obsolete. Again, the beautiful advantage of digital dentistry is that it can be used for patients where they have gag, where they have come for the second stage for uncovering. If there is not much bleeding, you can immediately record and minimize the number of visits to the office. So apart from the technological difference, image registration of adjacent surface in order to create a three-dimensional surface bigger than the field of view can sometimes increase angular errors over the length of the arch because there are too many images. Nevertheless, the errors are less than 0.2 degrees in most of the system, and with current new age intraoral devices from the likes of Itero, Serec, and the Trios 3 shape, I think so. I'm using the Trios 3 shape regularly, and we don't have so many issues with the processes, and the repeat lab works are almost at minimal. So, however, optimal results depend on using a high accuracy scanning protocol, which was found to involve an initial calibration with a calibration block. Now, this is something that if any dentist is already using intraoral scanner, they will understand. But it is not something that should be a deterrent. In fact, it's a small process to ensure that whatever you are recording is more accurate than what it appears to be. Conclusion. With the predictable integration of implants, the emphasis is shifted towards more precision with the restorative techniques and the creation of the tooth-like replacement for missing teeth. The efforts taken to precisely place implants and molds soft tissues must be translated to the master cast to allow the technician to fabricate good definitive restorations. Precise impression methodology would decrease the failures related to the suprastructure fabrication. Imprecise superstructure fit results in mechanical and biological consequences that disrupt the function of the dental implants. So again, just reconfirming that what we started off as emphasis is on planning, and planning involved your prosthetic phase and surgical phase. We have planned the surgical phase with the final processes in mind, and then placed your implant fixture, allowing it to heal, and going on to the next level, that is making impression either with the rubber base VP, polyether, or polyvinyl siloxane, or through the digital media. These are the few references we can share later.
Okay, so now let's take on to the last topic before we show you the cases. Let's discuss something about the implant-related failures and complications. आगे क्यों नहीं जा रहा है? Okay, there's some technical glitch. We are back. So types of implant complications. So sometimes you can see immediately when you place the implant, when you load the implants, you'll not see any complications, but some complications will come 5 years after the placement, 7 years after the placement. Some complications will be like fracture of processes. The crown might break. So some statistics are available with us which show that 13 to 15% of the prosthetic complaints or prosthetic complications are fracture of the crown itself. Another frequent complication that we come across is the loss of screw access hole restoration and screw loosening maybe. And abutment and screw loosening is most common in the lower mandibular first molar region because of the mandibular flexion. The abutment and occlusal screw fracture, that is also very frequent complication that we come across in some cases, but nowadays we have the retrieval kits and the retrieval systems to correct that complication. Fracture of implant is one of the rarest complication, and it's very rare. In my entire career, I must have placed around 7 to 10,000 implants, and I've seen only 2 to 3 implant fractures as yet, and those were for different reasons. So let's take it on one by one. Now, surgical complications. Surgical complications, you get hemorrhage and hematoma. So when do you have a hematoma? When you damage a nerve, blood vessel, or maybe during anesthesia, or also during the osteotomy. Most common sites of hematoma maybe are the lower mandibular incisal region, where you just there might be some unknown vessel and just drill into it, and then be a hematoma or a blood bleeding. So to control that, you need to have some hemostatic gels. The best is the hard compression. Just compress, give a hard pressure pack, and the hemorrhage will stop. Secondly, there might be some gels like Abgel, which is frequently available in India to stop the blood. Neurosensory disturbances or the damage to adjacent teeth. So when you are drilling, and sometimes there is a lapse of concentration or something, and you just hit the nerve, hit the canal, intra-alveolar canal. So that is a serious complication, and there will be paresthesia to the patient. And this paresthesia is most likely not reversible. So please stay away from the mandibular canal, intra-alveolar nerve, as long as possible. Stay away from it. If you feel you just have a 7 or 8 mm length, go for a cone beam CT, CBCT scan, and go for guided surgery. Go for a guided surgery so that you do not damage the nerve. So that is very important. Damage to adjacent. Sometimes when you're drilling, so you go deep inside, and if your angulation is wrong, so you might be applying pressure, but you feel that the drill is not going in completely. So that is really when you are hitting the root of the adjacent teeth during the apical area. So you damage the apical at the root of the adjacent teeth. That is one of the surgical complications that might occur. But as and when you practice, you place multiple implants, you will exactly know the angulation and blindly placing implants once you have experienced enough. Biologic complications, inflammation, of course, yes. Whenever there is a surgical process, the inflammation is the body's way of healing. So the inflammation will be there. But mucositis, if there is terrible inflammation which is not healing, which is not a sign of healing, then there is some sort of inflammation which might lead to some infection. Biologic complications and mucositis, again, then there's a lot of inflammation, pre-existing inflammation in the mouth. You are restricted. You cannot do your implant placement. Dehiscence and recession. What is recession? Recession is the coming bone level comes down. That is recession. That is much frequent in chronic periodontitis. And dehiscence is a bone defect. So whenever there is dehiscence, you have to go for a bone graft and then put your implant. If there is dehiscence and you might not, you don't correct it, so what happens is the threads are exposed, the implant will not integrate with the bone, and eventually the implant might fail. So peri-implantitis and bone loss, this is again a very huge concept. So peri-implantitis is inflammation around the periodontal area, around the peri-implant area. That usually happens once the prosthetic stage is done due to food lodgement, poor oral hygiene, or anything else. So there are multiple ways of correcting the peri-implantitis. One is the lower laser therapy, or you can use a laser. You can just use a hard scaler even. And nowadays, water jet comes. You can tell the patient to use the water jet to correct the food lodgement. Implant failure. So there are now implant can fail anytime, any given point. Even the best type of placement can fail. So you have no answer to implant failure. But once the implant fails, you'll have to go for a higher or width implant. And sometimes what happens is when you place an implant and there is bone loss. When there is bone loss, so you will see that there are some threads exposed. So you can use a titanium brush for cleaning the exposed thread, and again use a water jet to clear of the food debris every time when you have food. Mechanical complications, this we discussed earlier also, screw loosening and fracture. Screw loosening can happen anytime. Whenever there is screw loosening, you should be knowing where you have the center. So if you have an access hole, you just remove the composite, you just remove and you get inside the abutment, you put your hex driver and just tighten the screw, and your screw is fine. But if the abutment screw has fractured, then you don't have any option. You have to use a retrieval kit and get that fractured fragment out, then put a new abutment and give a new prosthesis. Implant fracture, that is a rare complication. Once it happens, if you have an implant fracture, you don't have any other option but to either to leave the fractured implant as it is inside the bone and find a site for new implant placement, or surgically, if it is not too deep, just surgically remove the implant, wait for the bone to heal, and then put a new implant. Fracture of the restoration, if the restoration fracture, of course, you have to go for new prosthesis. Aesthetic and phonetic complications. So aesthetic complications, you can see if the angulation of the implant is not good and the angulated abutment is not giving a proper thing, then the aesthetics will look a little bit weird. When there is deep bone loss, that happens especially in the upper maxillary region. When the crestal level is, the crestal bone loss is too much. So what happens is when you're restoring one teeth, that prosthetic will look too long and the adjacent natural tooth will look too short. So in such cases, you have to coordinate with your lab technician and tell him to use the pink ceramic or something and modify the prosthesis so that the aesthetics are not hampered. Phonetic problems. So these are a very rare type of complications, and I don't think so we need to discuss about that in this particular course. We move on to the next slide. A good prosthesis can always make your implant, but poor hygiene can break your implant. So that is what we have been discussing throughout our presentation. Implant placement, implant angulation, and the prosthesis. Perfect from functional prosthesis, taking care of the occlusion, bite, and every other factors which give a successful prosthesis can make your implant. But however good implant, however good prosthesis you give, but the hygiene is not good, or the patient has any systemic contraindications, then definitely that can break your implant, and the patient, you get married with the patient, and the patient will come to you again and again, correct, which is not correctable. Maintenance of implants, regular recall schedule, that is patient specific. So if it's a single implant or a double implant case, you might recall the patient for a regular checkup once a year or maybe once in 2 years. But if it is a full mouth case where the oral hygiene is also a little bit of a problem, so then you have to call the patient at least once in 6 months to check whether the food lodgement, is the patient maintaining good oral hygiene, is the food lodgement been cleared off, is he flossing properly, is he brushing properly, is he using those devices which you have suggested. Implant are subject to the same problems that the natural dentition is with respect to periodontal status. So if there is food lodgement, if there is a natural tooth, you will have crown, you will have cavities, you will have pockets, you will have gum infection. Similarly, even while having implants, if there is food lodgement, if you're not maintaining your good oral hygiene, Again, the same thing. There will be food lodgement, there will be peri-implantitis, there will be periodontal problems, bleeding gums, and everything. So you have to maintain the same way just as you maintain the natural tooth. These are few slides. You can see the margin of the implant, the margin of the prosthesis, and you can see the interdental brush, how to clean it. And you have to explain this, you have to show these slides. There are multiple videos available on YouTube, which you can show to your patient on how to clean the prosthesis. So coming to some of the cases, this is the case of a missing premolar. You can see on the left corner, you can see a very good bone, very good bone. And the sinus is also too far away. Here we place the implant and then the prosthesis, and the last X-ray is about 4 to 5 years after follow-up after the placement of prosthesis. So there you can see good bone, good crestal bone, hardly any bone loss. The bone loss is the same, and this patient is maintaining it well. Now coming to the next case, you can see the pre-operative radiograph. Now there was a missing two posteriors, 5 and 6 maybe, 6 and 7, first and second molar. Two implants were placed, indirect sinus lift was done. From crestal approach, Nova bone putty was used as for the grafting. And you can see good bone in the post-restoration X-ray, which dates back to 2014. And you can see the last 3-year follow-up, that is on 2018. The bone remains intact. There is no crestal bone loss. The prosthetic is good, and everything remains as it was 4 years back. This is the next case. This is, you see the multiple implants, 2 in the mandible, 2 in the maxilla. So you have the missing teeth in the maxilla and a few root pieces in the mandible. So extraction was done, implants were placed in both. Immediate implants were placed in this on the same day, as you can see. The date of the first radiograph is 14th December 2016, and the second radiograph on the right side is also 14th December 2016. Extraction, immediate placement was done, and look at that. The prosthesis was given after 6 months. We need to wait. And you can see in the OPG also, there was a follow-up for 1 year after the prosthesis was given. The bone level is maintained, the prosthesis is maintained. This is one of the cases. These are some photographs of the same case. Okay, no, I'm sorry, this is the photograph of the different patient. This was a full mouth hybrid prosthesis. Look at the importance of occlusion. See, the first photograph is in frontal normal occlusion. Second is the protrusive way. You can see the canine guidance. The third photograph is the mandibular occlusal, and the fourth photograph is the occlusal maxillary. Now you can evaluate the occlusion in these lateral views. The canine guidance and the lateral exclusive, left working and the right working, are also the extrusion photographs or lateral extrusions. So you can see it should be a clear and a smooth pathway. The canine guidance should be good, and the occlusion should be maintained. So this is how you should be maintaining the prosthetic part. Same way. And this is the radiograph of the same patient. You can see the day he came into the office and the placement of implants and the complete fixed ceramic prosthesis. This is another case. You can see the photographs, lateral photographs, and lateral excursive photographs also. And this was a single implant case. And this was also an immediate extraction case. So the patient had come with a root piece, and in no way it could have been saved. We extracted, we placed an implant, we restored it. And this is around 5-year follow-up. The last X-ray is the 5-year follow-up of the same case. You can see this, the occlusal pictures. Exclusive.
Things that may be used to compensate loss of pink.
Okay, so the pink ceramic you can see there. If you put, as I told you earlier, the aesthetic complications, when you find that the crestal bone has gone too down or recessed more, Here you can cover up with a pink ceramic, which is shown on the canine, upper canine, you can see. Again, this was the same thing, extraction and immediate placement of implant with good primary stability. Wait for 3 months to give the final processes, and the last photograph is 1 year follow-up of the same case. Now here, this everywhere we are seeing the IOPs and OPGs, but the most important tool when you are doing your implants in the initial phase of your career, IOP, I mean intraoral radiograph or the RVG is more important than any other thing, because it will give you the exact angulation, exact length, and exact detailing of where are you drilling, where are you going. So you can see the first photograph, that is the parallel pin that has been inserted. So to see the angulation and the correct placement. Second radiograph is the placement of implant, and then you see the prosthetic photograph and the follow-up radiograph. This is how the tissue should look like once in your second stage of surgery. This is again the Bioconcept BV system. Second stage surgery. This is the left photograph is when we uncovered the screw after removing the healing abutment. You can see such a beautiful gingiva there. This was ready for impression making, and on the right side, you can see the crowns which are placed. So this is recently done on Bioconcept BV system. A very fantastic system, and really Bioconcept loves the tissue.
Second view.
Yeah, Bina. This is again Bioconcept BV. You can see the edentulous first X-ray, first drill and the paralleling pin. Then the Bioconcept BV implant was placed inside. You can see the photograph wherein you can see such lovely tissue around the implant. And then the final X-ray with the final process in place. So now the good thing to look at the design of the implant. Look at the active threads. When you place this BV system, you will get such a beautiful torque, and you just love the way it goes inside, and you'll just enjoy placing these implants. So that's it from us. Thank you very much for being a patient listener. And I suppose this presentation was good enough for you to give a better understanding of implantology. Here we will now take a 1 hour lunch break. After the lunch break, we will first have a question and answer session wherein Joanna and Body will keep the questions ready. So once we take the question and answers, and then we will move on to the hands-on and the other parts of the presentation. So see you after the break. Thank you very much.